81. Which of the following is not part of the criteria for diagnosing metabolic syndrome? A. Increased waist circumference. B. Low HDL cholesterol levels. C. High LDL cholesterol levels. D. High blood pressure. Answer: high LDL cholesterol levels. Rationale: metabolic syndrome is diagnosed based on criteria such as increased waist circumference, low HDL cholesterol, high blood pressure, and high blood sugar. High LDL cholesterol is not part of the criteria. 82. Which of the following is a main reason why physical activity is recommended for managing metabolic syndrome? A. It directly lowers blood pressure. B. It increases HDL cholesterol. C. It increases LDL cholesterol. D. It causes weight gain. Answer: it increases HDL cholesterol. Rationale: physical activity helps raise HDL cholesterol, which is beneficial for metabolic syndrome. It can also reduce blood pressure and improve insulin sensitivity, but it does not increase LDL cholesterol or cause weight gain. 83. Which of the following medications is commonly used to treat high cholesterol in metabolic syndrome? A. Statins. B. Insulin. C. Metformin. D. Aspirin. Answer: statins. Rationale: statins are commonly prescribed to lower cholesterol levels in patients with metabolic syndrome. Insulin, option B, metformin, option C, and aspirin, option D, are not typically used for this purpose. 84. What is the primary reason that a high-fiber diet is recommended for people with metabolic syndrome? A. It lowers blood sugar levels. B. It increases triglyceride levels. C. It improves insulin sensitivity. D. It reduces blood pressure. Answer: it improves insulin sensitivity. Rationale: a high-fiber diet improves insulin sensitivity, which is beneficial for managing metabolic syndrome. While fiber can also affect blood sugar, option A, and blood pressure, option D, improving insulin sensitivity is the primary benefit. 85. Which of the following is a common cause of high triglycerides in people with metabolic syndrome? A. Excessive alcohol consumption. B. High-protein diet. C. High-fat diet. D. Overuse of antibiotics. Answer: excessive alcohol consumption. Rationale: excessive alcohol consumption is a common cause of elevated triglyceride levels, which is a key component of metabolic syndrome. High-protein and high-fat diets, options B and C, are less directly linked to high triglycerides. Antibiotics, option D, do not typically influence triglyceride levels. 86. What is the role of the liver in metabolic syndrome? A. It decreases insulin production. B. It is responsible for cholesterol production. C. It regulates glucose uptake. D. It detoxifies harmful substances. Answer: it is responsible for cholesterol production. Rationale: the liver plays a key role in cholesterol production, which can contribute to dyslipidemia in metabolic syndrome. While it does regulate glucose uptake, its role in cholesterol production is more directly linked to metabolic syndrome. 87. Which of the following conditions is most likely to cause insulin resistance in metabolic syndrome? A. Pregnancy. B. Obesity. C. Anemia. D. High blood pressure. Answer: obesity. Rationale: obesity is the most common cause of insulin resistance in metabolic syndrome, contributing to increased fat deposits that impair insulin action. Pregnancy, option A, anemia, option C, and high blood pressure, option D, can occur alongside metabolic syndrome but are not primary causes of insulin resistance. 88. What is the recommended initial treatment for managing metabolic syndrome? A. Surgical intervention. B. Lifestyle changes, diet and exercise. C. High-dose medications. D. Bed rest and hydration. Answer: lifestyle changes, diet and exercise. Rationale: lifestyle changes, including diet and exercise, are the first-line treatment for managing metabolic syndrome. Surgical intervention, option A, and high-dose medications, option C, are typically reserved for more severe cases. Bed rest and hydration, option D, do not address the underlying issues of metabolic syndrome. 89. Which of the following blood tests is commonly used to measure insulin resistance? A. Fasting blood glucose. B. HbA1c test. C. Fasting insulin level. D. Complete blood count. Answer: fasting insulin level. Rationale: fasting insulin levels are commonly used to assess insulin resistance. Fasting blood glucose, option A, and HbA1c, option B, provide information on blood sugar levels, but fasting insulin level is more directly related to insulin resistance. A complete blood count, option D, does not measure insulin resistance. 90. Which of the following is a common symptom of metabolic syndrome? A. Fatigue. B. Dry skin. C. Excessive hunger. D. Increased thirst. Answer: fatigue. Rationale: fatigue is a common symptom of metabolic syndrome, likely due to underlying insulin resistance and poor glucose control. Dry skin, option B. Excessive hunger, option C. And increased thirst, option D, may occur in some individuals but are less common. 91. Which of the following is an effective method to manage abdominal obesity in metabolic syndrome? A. Low-calorie diet and regular exercise. B. Liposuction. C. Antidepressant medication. D. Drinking more water. Answer: low-calorie diet and regular exercise. Rationale: a low-calorie diet combined with regular exercise is the most effective method for managing abdominal obesity, which is a central feature of metabolic syndrome. Liposuction, option B. Antidepressant medication, option C. And drinking more water, option D, do not directly target abdominal obesity. 92. Which of the following is a key component of the metabolic syndrome diagnostic criteria? A. High cholesterol levels. B. Abdominal obesity. C. Increased physical activity. D. High iron levels. Answer: abdominal obesity. Rationale: abdominal obesity is one of the core components of metabolic syndrome, along with high blood pressure, elevated blood sugar, and dyslipidemia. High cholesterol levels, option A. Increased physical activity, option C. And high iron levels, option D, are not diagnostic criteria. 93. Which of the following is an effective strategy for reducing the risk of type 2 diabetes in metabolic syndrome? A. Use of corticosteroids. B. Consistent physical activity and weight loss. C. High-sodium diet. D. Restricting fiber intake. Answer: consistent physical activity and weight loss. Rationale: consistent physical activity and weight loss are key strategies for reducing the risk of developing type 2 diabetes in individuals with metabolic syndrome. Corticosteroids, option A. High-sodium diets, option C. And restricting fiber intake, option D, are not effective. 94. Which of the following is a common lifestyle change recommended for managing high blood pressure in metabolic syndrome? A. Increased salt intake. B. Regular physical activity. C. High-protein diet. D. Smoking cessation. Answer: regular physical activity. Rationale: regular physical activity is essential for managing high blood pressure, which is a common feature of metabolic syndrome. Increased salt intake, option A. High-protein diets, option C. And smoking cessation, option D, are also important but less directly related to controlling blood pressure. 95. What is the role of triglycerides in the context of metabolic syndrome? A. They are markers of liver damage. B. They contribute to increased insulin sensitivity. C. Elevated levels contribute to cardiovascular risk. D. They help regulate blood pressure. Answer: elevated levels contribute to cardiovascular risk. Rationale: elevated triglyceride levels are a key component of metabolic syndrome and contribute to increased cardiovascular risk. They do not mark liver damage, option A, increase insulin sensitivity, option B, or regulate blood pressure, option D. 96. Which of the following is a protective factor against the development of NAFLD? A. Sedentary lifestyle. B. Moderate coffee consumption. C. High fructose intake. D. Obesity. Answer: moderate coffee consumption. Rationale: moderate coffee consumption has been shown to have protective effects against liver fibrosis and may lower the risk of NAFLD. Sedentary lifestyle, high fructose intake, and obesity are risk factors. 97. Which of the following hormones plays a key role in regulating blood sugar levels in metabolic syndrome? A. Glucagon. B. Insulin. C. Thyroid hormone. D. Cortisol. Answer: insulin. Rationale: insulin is the hormone primarily responsible for regulating blood sugar levels. In metabolic syndrome, insulin resistance leads to elevated blood sugar levels. Glucagon, option A, thyroid hormone, option C, and cortisol, option D, have roles in metabolism but are not the primary regulators of blood sugar. 98. What is a common feature of insulin resistance in metabolic syndrome? A. Increased glucose uptake by cells. B. Reduced glucose utilization by muscles. C. Decreased fatty acid levels in the blood. D. Increased protein breakdown. Answer: reduced glucose utilization by muscles. Rationale: in insulin resistance, cells, particularly muscle cells, are less responsive to insulin, leading to reduced glucose utilization. This contributes to elevated blood sugar levels. Increased glucose uptake, option A, and decreased fatty acid levels, option C, are not features of insulin resistance. 99. Which of the following is a key dietary recommendation for individuals with metabolic syndrome? A. Avoid all carbohydrates. B. Include more unsaturated fats. C. Consume a high-sodium diet. D. Focus on high glycemic foods. Answer: include more unsaturated fats. Rationale: including more unsaturated fats, such as those found in olive oil, nuts, and fish, is beneficial for managing metabolic syndrome. Avoiding all carbohydrates, option A, and consuming high sodium, option C, or high glycemic, option D, foods are not recommended. 100. Which of the following is a common risk factor for metabolic syndrome? A. Underweight. B. Sedentary lifestyle. C. High calcium intake. D. Vegetarian diet. Answer: sedentary lifestyle. Rationale: a sedentary lifestyle is a significant risk factor for metabolic syndrome, contributing to obesity, insulin resistance, and other related conditions. Underweight, option A, high calcium intake, option C, and a vegetarian diet, option D, are not typically associated with increased risk. 101. What is the primary purpose of using medications like metformin in metabolic syndrome? A. To lower blood cholesterol levels. B. To reduce insulin resistance. C. To decrease triglycerides. D. To control blood pressure. Answer: to reduce insulin resistance. Rationale: metformin is commonly prescribed to improve insulin sensitivity and reduce blood sugar levels in individuals with metabolic syndrome. It does not directly lower cholesterol, triglycerides, or blood pressure. 102. Which of the following is a typical complication of untreated metabolic syndrome? A. Anemia. B. Type 2 diabetes. C. Osteoporosis. D. Chronic kidney stones. Answer: type 2 diabetes. Rationale: untreated metabolic syndrome often progresses to type 2 diabetes due to persistent insulin resistance. Anemia, osteoporosis, and kidney stones are not direct complications of metabolic syndrome. 103. How does stress contribute to the development of metabolic syndrome? A. By increasing insulin sensitivity. B. By elevating cortisol levels. C. By reducing blood sugar levels. D. By decreasing blood pressure. Answer: by elevating cortisol levels. Rationale: chronic stress leads to elevated cortisol levels, which can increase blood sugar and fat storage, contributing to metabolic syndrome. Stress does not increase insulin sensitivity, option A, or decrease blood pressure, option D. 104. Which of the following is a direct benefit of aerobic exercise for people with metabolic syndrome? A. Increased fat mass. B. Improved cholesterol profile. C. Decreased bone density. D. Increased triglycerides. Answer: improved cholesterol profile. Rationale: aerobic exercise helps improve the cholesterol profile by increasing HDL and reducing LDL and triglycerides. It does not lead to increased fat mass, decreased bone density, or elevated triglycerides. 105. What is the main function of HDL cholesterol in the context of metabolic syndrome? A. To transport fat to tissues. B. To remove excess cholesterol from arteries. C. To increase triglyceride levels. D. To raise blood sugar levels. Answer: to remove excess cholesterol from arteries. Rationale: HDL cholesterol is known as good cholesterol because it helps remove excess cholesterol from the arteries, reducing the risk of cardiovascular disease. It does not transport fat to tissues, increase triglycerides, or raise blood sugar. 106. Which of the following is a common symptom of insulin resistance? A. Frequent infections. B. Darkened patches of skin, acanthosis nigricans. C. Brittle nails. D. Muscle cramps. Answer: darkened patches of skin, acanthosis nigricans. Rationale: acanthosis nigricans, darkened patches of skin typically found in body folds, is a common symptom of insulin resistance. Frequent infections, brittle nails, and muscle cramps are not direct symptoms. 107. Which of the following dietary patterns is recommended for reducing cardiovascular risk in metabolic syndrome? A. Low-fat, high-carbohydrate diet. B. Mediterranean diet. C. High-protein, low-fiber diet. D. High-sodium diet. Answer: Mediterranean diet. Rationale: the Mediterranean diet, rich in healthy fats, whole grains, fruits, vegetables, and lean proteins, is recommended for reducing cardiovascular risk in metabolic syndrome. Low-fat, high-carbohydrate diets and high-protein, low-fiber diets are less effective, and high-sodium diets should be avoided. 108. What is the primary role of triglycerides in the body? A. To store energy. B. To regulate blood sugar. C. To transport oxygen. D. To form cell membranes. Answer: to store energy. Rationale: triglycerides are the body's main form of stored energy. They do not regulate blood sugar, transport oxygen, or form cell membranes. 109. Which of the following is a common risk factor for developing fatty liver disease in metabolic syndrome? A. Regular physical activity. B. Excess body fat. C. High potassium levels. D. Low protein intake. Answer: excess body fat. Rationale: excess body fat, particularly abdominal fat, is a key risk factor for developing fatty liver disease, which is often associated with metabolic syndrome. Regular physical activity and low protein intake are not risk factors. 110. What is the main reason for monitoring blood pressure in patients with metabolic syndrome? A. To detect osteoporosis. B. To prevent cardiovascular complications. C. To assess kidney function. D. To check for anemia. Answer: to prevent cardiovascular complications. Rationale: monitoring blood pressure is critical in metabolic syndrome to prevent cardiovascular complications, such as heart attack or stroke. It is not primarily for detecting osteoporosis, assessing kidney function, or checking for anemia. 111. What is the primary hallmark of non-alcoholic fatty liver disease, NAFLD? A. Fat accumulation in the liver without significant alcohol use. B. Alcohol-induced liver damage. C. Autoimmune-mediated liver injury. D. Viral hepatitis infection. Answer: fat accumulation in the liver without significant alcohol use. Rationale: NAFLD is characterized by fat accumulation in the liver in the absence of significant alcohol consumption. Alcohol-induced damage, autoimmune liver injury, or viral hepatitis are not hallmarks of NAFLD. 112. Which imaging modality is most commonly used to diagnose NAFLD? A. X-ray. B. Abdominal ultrasound. C. CT scan. D. MRI. Answer: abdominal ultrasound. Rationale: abdominal ultrasound is the most commonly used imaging technique for detecting hepatic steatosis, a key feature of NAFLD. While CT and MRI can also be used, they are not first-line diagnostic tools. X-ray is not used for liver imaging. 113. What is the primary risk factor for developing NAFLD? A. Obesity. B. Low dietary protein. C. Excessive alcohol intake. D. Frequent infections. Answer: obesity. Rationale: obesity is the primary risk factor for NAFLD as it contributes to insulin resistance and fat deposition in the liver. Excessive alcohol intake is excluded in NAFLD, and low protein or infections are not primary risk factors. 114. What lifestyle modification is most effective for improving NAFLD? A. High-protein diet. B. Moderate weight loss. C. Avoiding fatty foods. D. Complete fasting. Answer: moderate weight loss. Rationale: moderate and sustainable weight loss, 5 to 10% of body weight, is the most effective lifestyle change for improving NAFLD. Avoiding all fatty foods or fasting is not recommended, and high-protein diets alone are insufficient. 115. Which lab test is most commonly elevated in NAFLD? H. Alkaline phosphatase, YLP. B. Aspartate aminotransferase, AST. C. Bilirubin. D. White blood cell count. Answer: aspartate aminotransferase, AST. Rationale: elevated liver enzymes, particularly AST and ALT, are common in NAFLD. While YLP and bilirubin may be normal or mildly elevated, white blood cell count is unrelated. 116. Which stage of NAFLD involves inflammation and liver cell injury? A. Hepatic steatosis. B. Non-alcoholic steatohepatitis, NASH. C. Cirrhosis. D. Hepatocellular carcinoma, HCC. Answer: non-alcoholic steatohepatitis, NASH. Rationale: NASH represents a more severe stage of NAFLD characterized by inflammation and hepatocyte injury. Hepatic steatosis involves fat accumulation only, while cirrhosis and HCC are later complications. 117. What is the recommended first-line pharmacologic treatment for NAFLD? A. Metformin. B. Pioglitazone. C. Vitamin E, D, statins. Answer: pioglitazone. Rationale: pioglitazone is recommended for select patients with biopsy-proven NASH. Vitamin E is an option for non-diabetic patients. Metformin and statins are not first-line treatments, but may be used for comorbid conditions. 118. What is the primary mechanism of liver damage in NAFLD? A. Chronic alcohol toxicity. B. Insulin resistance leading to lipotoxicity. C. Autoimmune destruction of hepatocytes. D. Viral infection of the liver. Answer: insulin resistance leading to lipotoxicity. Rationale: insulin resistance contributes to the development of NAFLD by promoting fat accumulation and lipotoxicity, which causes liver damage. Alcohol toxicity, autoimmune destruction, and viral infection are not mechanisms in NAFLD. 119. Which diet pattern is considered beneficial for NAFLD management? A. Ketogenic diet. B. Mediterranean diet. C. Low-sodium diet. D. Carnivore diet. Answer: Mediterranean diet. Rationale: the Mediterranean diet, which is rich in unsaturated fats, whole grains, and vegetables, has shown benefits for NAFLD management. The ketogenic and carnivore diets lack long-term evidence, and low-sodium diets address blood pressure, not NAFLD specifically. 120. What is the most severe potential complication of untreated NAFLD? A. Gallstones. B. Cirrhosis. C. GERD. D. Fatigue. Answer: cirrhosis. Rationale: cirrhosis is the most severe complication of untreated NAFLD, as it involves irreversible liver damage. Gallstones, GERD, and fatigue may occur but are not severe complications. 121. What does the term simple steatosis refer to in NAFLD? A. Fat accumulation with inflammation. B. Fat accumulation without inflammation. C. Scar tissue formation in the liver. D. Complete liver failure. Answer: fat accumulation without inflammation. Rationale: simple steatosis refers to fat buildup in the liver without inflammation or hepatocyte injury. It is a milder form of NAFLD compared to NASH, which involves inflammation and cell damage. 122. Which hormone is primarily associated with insulin resistance in NAFLD? A. Glucagon. B. Insulin. C. Leptin. D. Cortisol. Answer: insulin. Rationale: insulin resistance is a key factor in NAFLD pathogenesis, leading to excessive fat accumulation in the liver. Glucagon, leptin, and cortisol are not the primary hormones associated with this condition. 123. Which of the following is not a common extrahepatic condition associated with NAFLD? A. Type 2 diabetes. B. Polycystic ovarian syndrome, POS. C. Rheumatoid arthritis. D. Obstructive sleep apnea, OSA. Answer: rheumatoid arthritis. Rationale: extrahepatic conditions commonly associated with NAFLD include type 2 diabetes, POS, and OSA. Rheumatoid arthritis is an autoimmune condition and not directly linked to NAFLD. 124. What is the role of the fibrosis for FIB4 score in NAFLD management? A. Evaluates liver enzyme levels. B. Assesses risk of significant liver fibrosis. C. Predicts response to antiviral therapy. D. Diagnoses hepatocellular carcinoma. Answer: assesses risk of significant liver fibrosis. Rationale: the FIB4 score combines age, liver enzymes, AST/ALT, and platelet count to estimate fibrosis risk in NAFLD patients, helping prioritize those needing further evaluation like biopsy or imaging. 125. Which physical exam finding is most suggestive of advanced NAFLD? A. Jaundice. B. Palpable hepatomegaly. C. Splenomegaly. D. Spider angiomas. Answer: palpable hepatomegaly. Rationale: palpable hepatomegaly is a common finding in NAFLD due to liver enlargement from fat accumulation. Jaundice, splenomegaly, and spider angiomas are more commonly associated with advanced liver disease or cirrhosis. 126. What is the most significant histologic difference between simple steatosis and NASH? A. Fibrosis. B. Inflammation and hepatocyte injury. C. Fat accumulation in hepatocytes. D. Portal vein enlargement. Answer: inflammation and hepatocyte injury. Rationale: the transition from simple steatosis to NASH involves inflammation and hepatocyte injury, while fibrosis occurs later. Fat accumulation is present in both conditions, and portal vein changes are not diagnostic. 127. Which group is at the highest risk of developing NAFLD? A. Elderly individuals with no comorbidities. B. Overweight individuals with metabolic syndrome. C. Young adults with high alcohol consumption. D. Athletes with high protein intake. Answer: overweight individuals with metabolic syndrome. Rationale: overweight individuals with metabolic syndrome are at the highest risk for NAFLD due to insulin resistance and central adiposity. Alcohol use excludes NAFLD, and athletes are not typically at risk. 128. What is the gold standard for diagnosing NASH in NAFLD patients? A. Liver biopsy. B. MRI elastography. C. FibroScan transient elastography. D. Abdominal ultrasound. Answer: liver biopsy. Rationale: a liver biopsy is the gold standard for diagnosing NASH, as it provides definitive evidence of inflammation, fibrosis, and hepatocyte injury. Imaging techniques cannot confirm NASH, but may suggest fibrosis. 129. What is the primary cause of oxidative stress in NAFLD? A. Excess alcohol consumption. B. Mitochondrial dysfunction in hepatocytes. C. Vitamin deficiency. D. Bacterial infections. Answer: mitochondrial dysfunction in hepatocytes. Rationale: mitochondrial dysfunction in hepatocytes leads to increased oxidative stress, lipid peroxidation, and cellular damage in NAFLD. Alcohol and infections are not the primary contributors in NAFLD. 130. In patients with NAFLD, which lab marker is most commonly associated with fibrosis progression? A. Platelet count. B. Serum creatinine. C. LDL cholesterol. D. C-reactive protein. Answer: platelet count. Rationale: a low platelet count is often associated with fibrosis progression in NAFLD. It reflects worsening portal hypertension and impaired liver function. Other markers listed are not directly linked to fibrosis severity. 131. Which dietary habit is most strongly linked to the development of NAFLD? A. High fructose intake. B. High sodium intake. C. Low fiber diet. D. Vegetarian diet. Answer: high fructose intake. Rationale: high fructose intake, particularly from sugary beverages and processed foods, promotes hepatic fat accumulation and insulin resistance, increasing the risk of NAFLD. Sodium and fiber intake are less directly implicated. 132. Which genetic factor has been most strongly associated with NAFLD? A. HFE gene mutation. B. PNPLA3 gene polymorphism. C. BRCA1 mutation. D. CFTR gene mutation. Answer: PNPLA3 gene polymorphism. Rationale: the PNPLA3 gene polymorphism is strongly linked to an increased risk and severity of NAFLD. HFE mutations relate to hemochromatosis, and the others are unrelated to liver disease. 133. What imaging modality is most commonly used initially to screen for NAFLD? A. Abdominal ultrasound. B. CT scan. C. MRI. D. PET scan. Answer: abdominal ultrasound. Rationale: abdominal ultrasound is the most widely used initial imaging method for detecting hepatic steatosis due to its availability, low cost, and safety. CT and MRI are used for further evaluation when necessary. 134. Which medication class is considered first-line treatment for type 2 diabetes and NAFLD? A. Insulin. B. Thiazolidinediones. C. Biguanides metformin. D. GLP-1 receptor agonists. Answer: biguanides metformin. Rationale: metformin is the first-line medication for managing type 2 diabetes, a common comorbidity of NAFLD. It improves insulin sensitivity, but does not directly treat hepatic steatosis. 135. Which of the following lifestyle modifications has the greatest impact on improving NAFLD? A. Smoking cessation. B. Weight loss of 5 to 10% of body weight. C. Reducing alcohol intake. D. Increasing protein consumption. Answer: weight loss of 5 to 10% of body weight. Rationale: weight loss of 5 to 10% of total body weight has been shown to significantly reduce hepatic fat content and inflammation in NAFLD patients. Alcohol reduction is not relevant unless there is coexisting alcohol consumption. 136. In NAFLD, what is the main effect of adipokines such as adiponectin? A. Promotes fat accumulation in the liver. B. Reduces inflammation and fibrosis. C. Increases insulin resistance. D. Stimulates oxidative stress. Answer: reduces inflammation and fibrosis. Rationale: adiponectin has anti-inflammatory and antifibrotic effects in the liver, counteracting the processes that worsen NAFLD. Low levels of adiponectin are linked to increased severity of the disease. 137. Which scoring system is used to estimate liver fibrosis in NAFLD without biopsy? A. MELD score. B. NASH fibrosis score. C. Ranson's criteria. D. Child-Pugh score. Answer: NASH fibrosis score. Rationale: the NASH fibrosis score is a non-invasive tool that uses lab and clinical data to estimate liver fibrosis in NAFLD. MELD and Child-Pugh scores assess liver disease severity, but are not specific to NAFLD fibrosis. 138. What is the most common histological feature of NAFLD seen on liver biopsy? A. Hepatocyte ballooning. B. Portal vein thrombosis. C. Microvesicular steatosis. D. Macrovesicular steatosis. Answer: macrovesicular steatosis. Rationale: macrovesicular steatosis, characterized by large fat droplets displacing the hepatocyte nucleus, is the hallmark histological feature of NAFLD. Ballooning is seen in NASH, while microvesicular steatosis is rare. 139. Which patient population is at the lowest risk of developing NAFLD? A. Obese individuals. B. Individuals with metabolic syndrome. C. Underweight individuals with no comorbidities. D. Patients with type 2 diabetes. Answer: underweight individuals with no comorbidities. Rationale: underweight individuals without comorbidities are at low risk for NAFLD, as obesity and metabolic syndrome are the primary risk factors. 140. What is the role of omega-3 fatty acids in the management of NAFLD? A. Reduces hepatic fat accumulation. B. Increases insulin resistance. C. Promotes fibrosis progression. D. Decreases liver enzyme levels. Answer: reduces hepatic fat accumulation. Rationale: omega-3 fatty acids are believed to reduce hepatic fat content and improve lipid profiles in NAFLD patients. They do not increase insulin resistance or fibrosis and are not primarily used to lower liver enzymes. 141. Which laboratory test is most likely elevated in NAFLD? A. Alkaline phosphatase, (ALP). B. Serum bilirubin. C. Alanine aminotransferase, ALT. D. Prothrombin time, PT. Answer: alanine aminotransferase, ALT. Rationale: ALT levels are often elevated in NAFLD due to liver inflammation. While ALP and bilirubin may increase in advanced disease, they are not typically specific markers for NAFLD in early stages. 142. What is the role of bariatric surgery in the treatment of NAFLD? A. Induces fibrosis resolution. B. Prevents hepatocellular carcinoma. C. Improves steatosis and fibrosis. D. Cures NAFLD entirely. Answer: improves steatosis and fibrosis. Rationale: bariatric surgery can improve NAFLD by promoting significant weight loss, which reduces hepatic steatosis and fibrosis. However, it does not completely cure NAFLD or prevent all complications like carcinoma. 143. What is the primary purpose of transient elastography, fibroscan, in NAFLD? A. Detects fatty liver disease. B. Assesses liver fibrosis and stiffness. C. Identifies hepatocellular carcinoma. D. Measures liver enzyme levels. Answer: assesses liver fibrosis and stiffness. Rationale: fibroscan is a non-invasive test that measures liver stiffness and helps assess fibrosis in NAFLD. It cannot diagnose fatty liver disease alone or identify liver cancer. 144. Which dietary recommendation is most appropriate for a patient with NAFLD? A. High-fat ketogenic diet. B. Mediterranean diet. C. Low-protein diet. D. High-sodium diet. Answer: Mediterranean diet. Rationale: the Mediterranean diet, rich in fruits, vegetables, whole grains, and healthy fats, is beneficial for patients with NAFLD. High-fat, low-protein, and high-sodium diets are not recommended for liver health. 145. Which liver enzyme ratio is most characteristic of NAFLD? A. AST alt 2:1. B. Alt AST 2:1. C. AST alt equals 1:1. D. Alt AST equals 1:1. Answer: Alt AST 2:1. Rationale: in NAFLD, ALT is typically more elevated than AST, resulting in an ALT-AST ratio greater than 2:1. This distinguishes it from alcoholic liver disease, where AST tends to be higher. 146. Which of the following is the most common comorbidity associated with NAFLD? A. Hypertension. B. Hyperthyroidism. C. Hypercholesterolemia. D. Type 2 diabetes. Answer: Type 2 diabetes. Rationale: type 2 diabetes is strongly associated with NAFLD due to its link with insulin resistance and metabolic syndrome. Hypertension and hypercholesterolemia are also risk factors, but less strongly correlated. 147. What is the recommended frequency of liver function monitoring in a patient with diagnosed NAFLD? A. Every 6 to 12 months. B. Every 2 years. C. Every 3 to 4 months. D. Only when symptoms worsen. Answer: every 6 to 12 months. Rationale: regular monitoring of liver function tests every 6 to 12 months is recommended for patients with NAFLD to assess disease progression and ensure timely management. 148. Which histological feature is required for the diagnosis of NASH? A. Steatosis without inflammation. B. Steatosis with inflammation and fibrosis. C. Hepatocellular carcinoma. D. Portal vein thrombosis. Answer: steatosis with inflammation and fibrosis. Rationale: non-alcoholic steatohepatitis, NASH, is a subtype of NAFLD characterized by steatosis with inflammation and often fibrosis. Steatosis alone is indicative of simple fatty liver, not NASH. 149. What is the primary pathophysiological mechanism underlying NAFLD? A. Increased hepatic gluconeogenesis. B. Hepatic insulin resistance. C. Excess bile acid production. D. Portal hypertension. Answer: hepatic insulin resistance. Rationale: hepatic insulin resistance leads to increased lipogenesis, fat deposition in the liver, and the development of NAFLD. Portal hypertension and bile acid production are secondary to advanced liver disease. 150. Which biomarker is most useful in assessing liver fibrosis in NAFLD patients? A. Albumin. B. Platelet count. C. Alpha-fetoprotein AFP. D. FIB for index. Answer: FIB for index. Rationale: the FIB for index, which uses age, AST, ALT, and platelet count, is a non-invasive biomarker for assessing liver fibrosis in NAFLD. AFP is typically elevated in hepatocellular carcinoma. 151. Which of the following is the primary imaging modality used to diagnose NAFLD? A. CT scan. B. MRI. C. Ultrasound. D. Liver biopsy. Answer: C. Ultrasound. Rationale: ultrasound is the first-line imaging modality to detect hepatic steatosis due to its accessibility, safety, and cost-effectiveness. While MRI is more sensitive, it is less commonly used. Liver biopsy is invasive and not routine. 152. What percentage of liver fat is typically required for a diagnosis of NAFLD via imaging? A. 1 to 5%. B. 5 to 10%. C. 10 to 15%. D. 15 to 20%. Answer: B. 5 to 10%. Rationale: imaging studies like ultrasound or MRI require at least 5 to 10% of hepatic fat content to diagnose NAFLD. Lesser amounts may not be visible or clinically significant. 153. Which dietary component is most associated with increased risk of NAFLD development? A. Trans fats. B. High fructose corn syrup. C. Protein. D. Unsaturated fats. Answer: B. High fructose corn syrup. Rationale: high fructose corn syrup contributes to increased lipogenesis and fat storage in the liver. Trans fats also contribute to metabolic dysfunction, but are less directly implicated than fructose. 154. What is the primary mechanism of liver damage in NAFLD progression to non-alcoholic steatohepatitis, NASH? A. Viral infection. B. Oxidative stress and inflammation. C. Autoimmune response. D. Genetic mutations. Answer: B. Oxidative stress and inflammation. Rationale: oxidative stress leads to lipid peroxidation and subsequent inflammation, which drives the progression from simple steatosis to NASH. Viral infections and autoimmune responses are not primary mechanisms in NAFLD. 155. What histological feature is considered essential for diagnosing NASH? A. Ballooning of hepatocytes. B. Bile duct hyperplasia. C. Portal vein thrombosis. D. Presence of fibrosis. Answer: A. Ballooning of hepatocytes. Rationale: hepatocyte ballooning, along with inflammation and steatosis, is a key feature in diagnosing NASH. Fibrosis may occur later, but is not required for the diagnosis of NASH itself. 156. Which liver enzyme pattern is most commonly seen in patients with NAFLD? A. ALT AST. B. AST ALT. C. Both ALT and AST normal. D. Elevated alkaline phosphatase only. Answer: A. ALT AST. Rationale: in NAFLD, ALT levels are typically higher than AST, reflecting liver injury primarily related to fatty infiltration. This is the reverse of alcoholic liver disease, where AST is usually higher than ALT. 157. What role does adiponectin play in the pathophysiology of NAFLD? A. Promotes insulin resistance. B. Reduces inflammation and fibrosis. C. Increases hepatic fat storage. D. Stimulates lipogenesis. Answer: B. Reduces inflammation and fibrosis. Rationale: adiponectin is an anti-inflammatory hormone that protects against NAFLD progression by reducing liver inflammation and fibrosis. Lower levels are associated with advanced disease. 158. Which medication is recommended as first-line treatment for diabetes and may also improve NAFLD? A. Metformin. B. Sulfonylureas. C. Pioglitazone. D. Insulin. Answer: A. Metformin. Rationale: Metformin, while not approved specifically for NAFLD, improves insulin sensitivity and may have secondary benefits for patients with NAFLD. Pioglitazone is an alternative, but not first-line due to potential side effects. 159. Which of the following is the strongest predictor of fibrosis progression in NAFLD? A. Obesity. B. Diabetes mellitus. C. Persistent inflammation. D. Age over 50 years. Answer: C. Persistent inflammation. Rationale: persistent inflammation drives fibrosis progression in NAFLD. While diabetes and age are risk factors, inflammation is the most direct predictor of advancing liver damage. 160. Which tool is commonly used to assess the risk of advanced fibrosis in NAFLD patients? A. FIB-4 score. B. MELD score. C. Child-Pugh score. D. APRI score. Answer: A. FIB-4 score. Rationale: the FIB-4 score is a validated, non-invasive scoring system used to assess the likelihood of advanced fibrosis in NAFLD patients. The MELD and Child-Pugh scores are used primarily in liver failure cases.